important message, and one that unfortunately is not adhered to often enough, is that every instance of visible blood in the urine needs to be investigated. In my experience, probably a third to a half of the time people will void blood. They or their family doctor or the emergency doctor will assume it was an infection. They're given antibiotics. They're often sent home. The bleeding always stops. The bleeding always does stop. You have a nosebleed, it stops sooner or later. And they assume that whatever it was has passed and that there's no longer a problem. So I would say that most of the people I see in that situation are seen only after the second or third episode when it occurs. Typically it starts off with two investigations. One is some sort of imaging, usually an ultrasound, occasionally a CT scan, and cystoscopy, the scope that I'm sure you've all been through way too many times. It's unpleasant, but that's how these things get found. There is no imaging that will find a small tumor. Okay? A normal ultrasound does not mean that it's not there. So we do the scope, and we find a tumor, usually in the form of a polyp, a growth in the bladder. It would be biopsied and ultimately removed. There are two qualities that a tumor can have, and we base all of our decision making on those two qualities. One is the grade, in other words, how aggressive is it? The other is the stage. How deep does it go into the bladder? As far as the stage is concerned, most bladder tumors are just sitting on the inside surface of the bladder. They do not go deep. And as long as that is the case, the grade, at least initially, doesn't matter. It doesn't matter whether it's aggressive or non-aggressive. It's been caught in time. Now I'll come back to that point because there is a decision to be made at that level. But suffice it to say that in most cases, if the pathologist comes back and says, good news, it was just on the surface, it had not invaded deep into the muscle of the bladder, we can then say to the patient, well, good news, it's been caught in time, things are okay for now. On the other hand, if the tumor is found to have invaded deep into the muscle of the bladder, again, the grade really doesn't matter anymore because within the muscle of the bladder is a very rich supply of blood vessels and lymphatics, and that is a cancer cell's highway out of the bladder. That's how cancer cells travel to the rest of your body. So that if we see a bladder cancer that is muscle invasive right at the start, well then, in most instances, we would recommend more aggressive treatment, usually a combination of chemotherapy and ultimately removal of the bladder, or chemotherapy and radiation of the bladder. And you can never really assume that you've gotten it all once the tumor's into the bladder muscle. So the first branch occurs based on the stage of the tumor. So that group goes off for chemotherapy plus radiation or surgery, but the next group, where it was caught in time, we say, okay, for now at least, we're fairly sure that we've gotten it all. And then you come back for checkups. Typically about every 3 or 4 months in the first year, typically every 6 months in the second year, and then generally once a year after that. One of two things then happens. Again, the branch. Some people are very fortunate and they may never have another tumor, or they may have other tumors, but again, they do not show any sign of what we call grade or stage migration. In other words, they may come back, as yours did, but they don't get any worse. Okay, they are still superficial, meaning they have not invaded the muscle, and they don't show any sign of becoming more aggressive in their nature. So as long as that is the case, you can just go along and just keep right on scraping them off. In some of those instances, we will give that group of patients BCG. Again, we have one group who has one tumor and never seems to have another one. We have another group who have tumors, but they show no sign of grade or stage migration. Some of them may have frequent recurrences, and we use BCG to try and decrease the number of recurrences. I have patients who've had superficial recurrences for 25 years, except for the fact that it drives us both crazy to have to go in and deal with them all. They'll never die of their disease, they just keep coming back. And you have a group that show what I'll call red flags. They have recurrences, but as the recurrences come back and back and back, either they come back in a more aggressive form, even though they haven't invaded yet, or they show signs as you get them starting to invade a little bit deeper and a little bit deeper. You start to get more dangerous tumors, which even though you've caught in time. And those are the most difficult. You know, a person's bladder is, as I don't have to tell so many people in this room, it's a terrible prospect to have to confront.